Picture this. A family at the discharge desk with a pile of papers, a wheelchair by the door, and half the team saying different things. They smile, they thank the staff, and they leave, relieved but worried. I've been that nurse. I've seen how one clear checklist changes everything. Welcome to the podcast. I'm Jess, a family nurse practitioner and legal nurse consultant, and this is the space where healthcare, law, and real-life situations intersect. Let's make hospital discharge simple and safe.
Here's what we'll do. I'll walk you through the single most important paper you get, how to handle medications without guessing, who to call and when, and the exact red flags that should make you stop and call for help, plus scripts you can use word for word.
First, the discharge summary. Think of it as the medical story of your stay and the roadmap for the next days. Most people tell me it looks like alphabet soup.
Quick checklist for that page. Diagnosis. Does the wording match what you were told? Hospital course. What actually happened? Pending items. Any labs, images, or consult notes still outstanding?
If something reads like a code, say AKI or NSTEMI, ask them to say it in plain language. Use this one-sentence script. Can you tell me in one sentence why I was admitted and what changed because of the treatment?
Now, medications, the spot where most mistakes hide. Medication reconciliation is just comparing 3 lists: what you took at home, what you got while admitted, and what you're being sent home with. Simple in concept, tricky in practice. Start with a printed list. Put home meds and discharge meds side by side. Circle anything new, anything stopped, and any dose changes. Don't leave without that printout. Flag high-risk drugs, blood thinners, insulin, opioids, psychiatric meds, and anything with big interactions. Ask, which of my home medicines should I stop, and who will notify my primary care or specialist about these changes? I'll be blunt. I once watched a patient leave with both the hospital insulin and their old insulin. They lived 2 hours from the nearest clinic. It almost ended poorly. That's why this step matters. Get it in writing.
Don't skip the pharmacist. Can you review my discharge medication list with me and explain any new drugs, side effects to watch for, and what to do if I miss a dose? Also ask, do any of these interact with my other meds or supplements? 2 short pharmacy lines you can say out loud. Please tell me which pills are new, which I should stop, and what each one is for. And, if I feel X side effect, should I stop the med or call my provider? Clear? Short. Actionable.
Next, follow-up appointments and home supports. Prioritize by risk. Which appointments need to happen in the next 24, 48, or 72 hours? Which can wait a week?
Concrete examples, not rules, but common practice. If you're on warfarin, ask for an INR check in 48 to 72 hours. New insulin? Plan follow-up in 24 to 72 hours. Wound checks or suture removals are often 48 to 72 hours or 7 to 10 days, depending on the procedure, so get a date before you leave. I need my INR checked within 48 hours. Who will set that up? Can you schedule my wound check within the next 48 to 72 hours and give me the clinic phone number now? Ask for written confirmation. If you need equipment, oxygen, a hospital bed, a walker, ask the case manager. Who will coordinate the equipment and when will it arrive? If home health is planned, ask how many visits, what tasks they'll perform, and when the first visit will be.
Curious. 1-page follow-up plan. Make it now. Write the next appointment and date, the key meds to watch, pending tests, and 2 phone numbers, primary contact and backup. That single note will save you confusion later.
Now, red flags. These are not vague. They're signals you should call right away or return to the ED. Examples to memorize: sudden worse breathing, new chest pain, new confusion, uncontrolled bleeding, fever over 101.3 F, 38.5 C, rapidly increasing pain, or wound changes, more redness, swelling, drainage, or a foul smell. Escalation script to keep handy. I was discharged from the hospital and I'm having X symptom. I was told to call for Y, and here's how it's changed. Brief description. Do I need immediate care? Short, factual, and it forces a clear triage response. A couple of short reminders before we wrap. Don't leave confused. Don't assume the hospital notified everyone, and don't be embarrassed to ask the same question twice until you understand it. 3 quick takeaways you can use right now. 1. Get a plain language discharge summary and ask the one-sentence question, why was I admitted and what changed? 2. Reconcile meds with a pharmacist and use the 2 pharmacy lines we practiced. 3. Schedule your highest priority follow-up now and write a single follow-up plan with names and phone numbers. A live action template to say at discharge, please print my discharge summary in plain language and write the key follow-up dates and phone numbers on it. Short, specific, hard to ignore. If this episode helped you prepare for a hospital discharge, subscribe for more practical checklists you can use today. Share it with a caregiver or family member who might be leaving the hospital soon. If you want more tools, templates, or a consult for a complex discharge or case, you can learn more at FAQ by NurseJessicaConsulting.com. I work with attorneys, organizations, and professionals who need clear medical insight when details matter. Thank you for listening. Until next time, stay informed, stay compassionate, and always put safety first.